Welcome to OMIC's webinar entitled Great Expectations, Liability Risks of Unrealistic Surgical Goals. My name is Ann Menke, and I'm the Patient Safety Manager for OMIC. I have no financial disclosures. I'm employed, as I mentioned, as the Patient Safety Manager. The photos shown are not those of the actual plaintiffs in these lawsuits. While I created the course, it greatly benefited from the reviews provided by Dr. Christopher Rapuano, a corneal specialist on OMIC's board, Linda Harrison, the Director of Risk Management, and our two risk managers, Hans Brun and Michelle Pineda. When we're talking about unrealistic surgical goals, it's important to distinguish between the benefits that surgeons are required to disclose as part of the informed consent discussion and what the patient's goal is for the surgery. Benefits are what the surgeon expects the surgery to accomplish. Goals are what the patient believes or hears about what the surgery can accomplish. And the course is going to address the question of what happens if you and your patient have different goals and expectations. I've chosen cases that illustrate the range of disconnection between ophthalmologists and their patients, and I'm going to summarize the medical care quickly and focus on the communication challenges. So whose great expectations are we addressing in this course? I decided to focus on patients seeking definitive surgical treatment, and the three cases are adult strabismus, functional and cosmetic lid surgery, and premium IOLs. This course doesn't explicitly address patients with chronic conditions such as glaucoma and age-related macular degeneration. They need long-term monitoring and treatment and may need repeat treatment. The issues are the same, but we're not going to explicitly address those in this course. Let's first look at adult surgery. In this case, this was an adult patient whose left eye had drifted outward since childhood. He developed eye discomfort with visually demanding tasks, especially when he was tired, and had taken his daughter to an ophthalmologist, and while there asked about possible solutions for his own problem. The exam showed poorly controlled intermittent left exotropia of 20 prism diopters for distance and 30 for near. And after discussing his situation with his daughter's ophthalmologist, he decided he wanted to proceed to surgery. There was an extensive informed consent discussion that addressed the known and major risks: under and overcorrection, diplopia, the need for additional surgery, the loss of sight, and infection and bleeding. The patient suffered a known complication of significant diplopia, and after surgery developed variable intermittent left esotropia up to 20 prism diopters, and the physician prescribed a prism to address this. 2 weeks after the surgery, the patient had between 9 and 15 diopters of esotropia, and the physician prescribed a medication to reduce the variability and magnitude of it. At the third postoperative week, the ophthalmologist learned that the patient hadn't even obtained the drops yet. At this point, he had less than 10 diopters of esotropia and was able to fuse between 8 and 12 diopters. They decided jointly to try the drops, and he explained to the patient that he might need another surgery. At 4 weeks, the diplopia persisted, but was down to 9 diopters. The physician noted that while the patient reported small symptomatic improvement, there was no significant change in the measurements. He again asked the patient to try the drops in the prism. The patient called the next day and said he had decided he did want surgery. At postoperative week 6, there was significant improvement, even though the patient had not worn the prism glasses or used the drops. At this point, he had 4 prism diopters in the primary, 4 in the right, 8 in the left, and was able to fuse at near with no esotropia. At this point, both the physician and the patient agreed to cancel the surgery as he was improving, and the patient never returned. He went on to seek second opinions from 2 academic experts, both of whom advised him to wait since the diplopia was clearly improving. Nonetheless, he filed a claim. When OMIC's board member reviewed the case, he was strongly supportive of the care. When the plaintiff attorney was advised of the positive review, he decided not to pursue the case, so it was dismissed and closed without payment. Let's look at some risk management issues here. From the patient's perspective, although he had lived with strabismus for a long time, he decided to have the surgery and wanted a quick and complete resolution in his appearance and vision. However, he didn't like wearing the prism. The drops gave him a headache, so he wasn't willing to cooperate with the care needed to improve his postoperative condition. The physician's perspective was this was a long-term problem. He expected and felt that he had achieved slow improvement in alignment and diplopia following the surgery. He summed up this patient as high maintenance, but not unreasonable. He understood exactly why the patient wanted things to move quickly. Our academic expert shared his opinion that, of course, the patient was disappointed, but waiting for this slow, gradual improvement was far superior to Botox or additional surgery. So in a patient like this, the challenge is, how do you help a patient who's young, conscious of his appearance, wait for it to improve? How do you help him prepare for up to 6 to 8 weeks of waiting while his eye heals from surgery? So one idea is to cultivate resiliency. So here's some possible things you might say. At the initial visit after surgery, when he was found to have diplopia, you could say, we talked about this new complication, known complication before surgery, but I'm sorry you got it. And I know that double vision can be very hard to deal with. Do you think you'll be able to work? Will you be able to drive? You can also explain that the healing process can take quite a while and explicitly ask, what can I do to help you handle the double vision during that time? At the second visit, you could say, the prism wasn't enough, so I'd like you to try some drops. You can also check in and say, it's been 2 weeks. How do you feel about the time this is taking? And what problems besides double vision is this causing you? At the third week, you can discuss the drops with the patient and say, I think they would help. You didn't fill the prescription I gave you last week. Would you be willing to try the drops now? It is important to notice and document when patients aren't following treatment recommendations, but it's much more helpful to take this team approach rather than scolding a patient for not doing what you've asked him or her to do. At week 5, you can thank the patient for his willingness to take the drops and remind him you might need another operation, but I'd like to give your eye more time to heal and continue with the prism and drops. Are you willing to wait? Often surgeons tell the patient the information they want them to hear, but don't ask them explicitly, are you willing to go along with this? This can help the patient feel more like a member of the team, but also make it clear whether the patient understands your explanation and treatment plan and is willing to cooperate with it. In each of the cases, I'm going to ask the question of a refund. So here's a patient who had strabismus surgery, suffered a known complication, slow, gradual improvement. Should you offer a refund for this procedure? My personal opinion is that refunding fees for a known complication sends the wrong message. For a particular patient, it might be the right thing to do. You know your patient better than anyone else. If you do decide to refund the fees, consider contacting our claims department and asking for a release. This is a document that the patient signs stating that in exchange for this refund, he won't pursue legal action. Because it's a legally binding document, we need the defense attorney in your state to draft it, and so you do have to go through our claims department. Let's go on to another case, that of eyelid surgery. This patient had ptosis and presented with it in the forehead and eyebrow area. He also had eyelid involutional ptosis and dermatochalasis. The visual field test confirmed that his upper lid problems did interfere with vision. Sorry, it was a female patient. And thus, this patient met the criteria for functional upper eyelid surgery. The patient agreed to surgery for these functional problems and understood that that would be covered by Medicare. The patient also had some issues with the lower lids and wanted cosmetic surgery at the same time to address those. She said she understood that she would have to pay for this herself and signed the advanced beneficiary notice acknowledging that the cosmetic lower eyelid surgery would not be covered by Medicare. So for the upper lid functional surgery, the ophthalmologist did an internal ptosis repair, blepharoplasty, and a frontalis ptosis repair. And for the lower lid, did a transconjunctival blepharoplasty with excision of lateral skin. The patient developed some postoperative problems. One was a small granuloma in the temporal left lower lid. This was excised and resolved. However, she had a persistent web in the medial aspect of the right upper lid. The ophthalmologist treated this with multiple Kenalog injections and then performed what he described as touch-up surgery in his office. He did not offer any other surgical treatment options. After 10 months, the ophthalmologist finally did offer the patient a second opinion with his partner. The patient also went to see 2 other physicians, so got a range of opinions on this. All 3 recommended a Z-plasty, and she decided she wanted one of the outside physicians to do the surgery. She sent a demand letter to her ophthalmologist. At that point, she had no attorney. She requested money to pay for the surgery by the plastic surgeon, and so estimated that that would cost $5,660. She also felt that the 18 months of pain and suffering merited some kind of compensation, and she asked for $15,000 for that. We had the care reviewed by one of our oculofacial plastic surgeons on our board, who noted that a web is a known complication of blepharoplasty. Since the physician met the standard of care for functional upper lid surgery, we denied the claim. However, the concern was voiced that the surgeon didn't do anything for 18 months despite persistent complaints and didn't offer other surgical alternatives such as Z-plasty or a skin graft. But since the care met the legal standard of what a reasonable physician would do, we denied the claim. The statute of limitations passed, and this one also closed without payment. Let's look at some risk management issues connected with this eyelid surgery case. From the patient's perspective, reported her concerns about the upper lid for 18 months and often in writing. She continued to get treatment from our defendant ophthalmologist and to communicate her concerns and desires, but she was repeatedly told, in her words, to be patient. Remember that the ophthalmologist had offered her a touch-up in the office, and she felt that not going back to surgery showed that the physician was trivializing her concerns. And she also said that she would willingly have paid for cosmetic upper lid surgery if the surgeon had explained those options to her when she developed the persistent web. The defendant's perspective was, I think, really an apt description of the situation. He said this patient wanted an advanced cosmetic result on an insurance budget. What lessons could be learned? The reviewer pointed out that the treatment of the persistent web was reasonable but not sufficient to solve the problem. When this review was shared with the defendant, he recognized that he hadn't done that and changed his practice and says he now offers surgical treatment earlier in the postoperative period. He also works harder to explain to the patient the difference between functional and cosmetic surgery, and he reports us this has made a big difference in his practice and in his patient's satisfaction. It's really important to explain options and costs to patients. This happens not only in lid surgery, but also patients who opt for premium IOLs, which cost them more money, and then have some problems after them. These, of course, are not uncommon after premium IOLs. You always have to clarify what is and is not covered by Medicare. Medicare covers standard monofocal IOLs with cataract surgery, but not premium IOLs. And you want to be careful not to offer options that aren't in the particular patient's best interests. Should you offer a refund? It's important to note that waiving or refunding fees is not legally an admission of liability unless you say, I'm sorry that I. So we encourage you to say, I'm sorry that you. I'm sorry that you're disappointed in the results. I'm sorry that you're not seeing as well as we both expected. Offering a refund may appease the patient and be seen as a very caring gesture. On the other hand, we've had instances where a patient who didn't think anything had gone wrong decided that it was malpractice once a refund was offered. You should know, however, that many ophthalmologists consider refunds after cosmetic procedures or premium IOLs to be a smart business decision, so it's not uncommon to offer to refund in these situations. Let's look now at a premium IOL case. This patient had clear, high expectations from the start. He was an engineer who originally presented for a LASIK evaluation, but the exam revealed early cataracts. He was given a trial with contact lenses and advised not to have the LASIK, but to wait instead until the cataracts worsened. The physician noted in the medical record that the patient had higher than average expectations. This patient was not in a hurry and was willing to wait for what he considered the best. He knew that multifocal IOLs were improving, so he opted to wait as designs changed because he wanted high quality vision at all three distances. He currently wore bifocals. He did not ever want to wear glasses again. 2 years after the initial exam, when his reported problems with poor night vision and glare indicated a decreased best corrected visual acuity of 20/40, he was then advised he could proceed with surgery. The surgeon appreciated how engaged the patient was and how many details the patient wanted, so he sent him links for all available premium IOLs. The patient wanted the most advanced presbyopia correcting IOL and again reiterated that he wanted high quality vision at all distances. He was advised that he had pre-existing astigmatism and had a 10 to 20% chance of needing PRK for optimal results after his cataract surgery. His surgery was uncomplicated. On the first postoperative day, his uncorrected vision was 20/60-1, but he said he didn't have time for a full visit, so he only had a limited exam. At postoperative day 7, the uncorrected visual acuity had improved to 20/30-, and his near vision was J1 plus at 14 inches. The exam noted mild hyperopia and cylinder, and the patient was advised that his eye was still healing, that he had some dry eye and some corneal edema, but that improvement was expected. At postoperative week 4, again, continued improvement. At this visit, the surgeon wasn't available. He saw an optometrist in the practice and voiced his unhappiness that the surgeon wasn't there that day. The optometrist demonstrated the improvement he could expect with glasses and gave him a prescription for them. But because it was clear the patient really wanted to speak with the surgeon, an appointment was scheduled for a week later. At that appointment, the patient had 20/20 minus J4 vision with correction for hyperopia and astigmatism. The surgeon told him that he would perform the PRK that they had previously discussed at no additional charge, but they needed to wait for the prescription to stabilize. The patient wanted more details again about his IOL, so the ophthalmologist sent him an article that had just been published about his restore. He, however, was not willing to wait for his prescription to stabilize, and he requested a copy of his records for a second opinion. The physician encouraged him to get this second opinion and waived the copying fee. The patient never returned. He engaged an attorney who wrote a letter to the physician, who explained that the patient went to an academic center and had an IOL exchange and had decided to have a monofocal lens. Soon after his second procedure, he needed a YAG. The physician who performed the IOL exchange and YAG opined that multifocal IOLs do not offer high resolution at all three distances, and he implied by his remarks in the medical record that this IOL was not an appropriate choice for the patient and that the incision was too large. Citing this other physician's criticism, the plaintiff attorney asked in writing for $15,000. A letter on the physician's behalf back to the plaintiff attorney, stating that we were sorry his client wasn't satisfied with what we emphasized was the initial outcome, and also clarified that it was the patient who chose to leave before completing the recommended treatment plan. We respectfully declined to pay and asked the attorney to contact OMIC if he wished to pursue this. He did. He reminded us that the subsequent treating physician was willing to testify and now increased the demand to $28,000. And he gave us authorization to obtain subsequent treaters' records, which are really helpful because we hear that sometimes subsequent treating physicians are critical of the prior care, but when we get the records, that's not what happened at all. While we were waiting for the records, the patient went ahead and filed a lawsuit. He alleged negligence, lack of informed consent, and intentional infliction of emotional distress. This intentional claim was immediately challenged and dismissed. In his deposition, the plaintiff testified that yes, he had read the 7-page consent form with great care, especially the sections on complications and the possible need for an IOL exchange. He acknowledged that the surgeon had repeated detailed informed consent discussions with him. He also surprised us by saying that he and the physician agreed at the first visit that he had high expectations. But he ended by saying that the IOL didn't give him what he asked for. Our outside defense expert opined that this case was totally without merit. He pointed out that the patient had an excellent final outcome, and it was just one of many patients who were unable to adjust to multifocal IOLs. He also pointed out that the patient did not return to the surgeon for treatment. He noted that the patient developed PCO and needed a YAG, but that this is a well-known complication, not evidence of negligence. He was critical of the speculative comments made by the second surgeon in the medical record. Our defense attorney advised the plaintiff attorney of the strongly favorable defense expert review and of the criticism of the comments his expert had made. That convinced the second surgeon to withdraw as the patient's expert. And so the patient dismissed the case. The plaintiff went on to post a negative Yelp review. Beware of Dr. X. He overpromises. He recommends expensive and inappropriate lenses. He doesn't advise of compromises to vision after surgery, and he didn't apologize or offer a refund for failed surgery. Our defense attorney reminded the plaintiff attorney that the plaintiff dismissed the case with prejudice, which means he can't sue again, and they didn't have any expert willing to testify. He also pointed out that the comments on Yelp might be construed as defamation. He asked the plaintiff attorney to remove this immediately. We didn't hear any more from our insured physician, so we assumed that they were indeed removed. So in this case, both the plaintiff and the defendant were in agreement, and the ophthalmologist was happy to work with such an engaged, detail-oriented patient. They had explicit communications about the goal and had detailed information. The one thing the ophthalmologist did not explore is how the patient would feel if he didn't achieve his goal. He was clear he wanted high-quality vision at all three distances, and perhaps that should have been a clue to walk away because you can't really guarantee that. So, a couple of ways to raise this question. I understand your goal and believe this IOL will meet it, But how will you feel if you don't get the vision you want? Will you feel like the surgery was worth it? You have to be willing to walk away. And a patient like this who keeps explicitly stating that he wants perfect vision is probably not someone you want to do surgery on. And you can just say, I'm not comfortable proceeding since I can't guarantee the outcome you want. Should you offer a refund? If the outcome is the result of an error, it turns out that it was the wrong IOL, then we do advise you to waive or refund your own fees for both the prior surgery and the subsequent procedures. We believe you should also apologize. This is often very effective in mitigating patient anger and preventing a lawsuit. You have to clarify, however, what fees will be waived and for how long, because some patients have understood this to mean free eye care for life. If you want to offer a refund in response to a written demand, by policy terms, you have to discuss this with our claims department, because refunds issued after a written demand may need to be reported to the National Practitioner Data Bank. It's also important to realize that some plaintiffs may be willing to accept less money than they demand. If you are interested in paying the fees of another physician, ask the physician to bill you directly. This means there's no loss of money for the patient, ensures that the money is used for remedial medical expenses, and the amount paid then will equal the actual cost. However, this is considered an indemnity payment. You have to contact your professional liability insurance company and get permission to do this. What's the best approach to negative online reviews? It's important to realize that free speech is protected, and this includes personal opinions and perceptions, and these opinions and perceptions do not have to be accurate. You are handicapped in responding to negative online reviews because you have to abide by HIPAA. You have to protect the patient's confidentiality. You can't even acknowledge that this is a patient of yours. Some approaches that have worked are to contact the patient if you know who's posted the review and offer to discuss the concerns. If the patient is uncooperative or difficult, follow your usual response process. You can also contact the site and explain that you feel this is fraudulent or inaccurate. You can seek a subpoena. You'll have to consult an attorney first. You could file a lawsuit showing that this is inaccurate and causing harm, but these are all very expensive and difficult proceedings. There's a more detailed explanation of this on our website in an article called You've Been Yelped. If you have questions about the course or your own particular patients, we encourage our policyholders to contact our confidential risk management hotline. And here's the email and phone number for that. And we have many resources that can help you at omic.com. Thank you very much for listening to this, and we hope that you found helpful in it.